afternoon. I will be discussing Transcatheter VSD Closure using multifunctional occluder device. VSD is the common of all congenital heart disease, which amounts to about 20% of all defects. Surgery still remains the gold standard for the treatment of VSD, and interventional closure has been performed as an alternative treatment in many types of VSD. Transcatheter closure was initially described by Locke. In his study, 7 defects and 6 were successfully closed. Modern era started development of occluders and technique which leads to a higher rate of success. Percutaneous treatment of VSD has brought hope and disappointment, bringing this treatment in question, but new devices and designs were newly introduced that might lead to its high procedural success with less complication. Our institution started our VSD device closure program last 2012, which yielded good result. Luckily, we haven't experienced post-procedural complete heart block or any major complication. Last 2016, we started our VSD closure with multifunctional occluder device. Our initial results revealed as follows. The age range from 3 to 20 years of age, with a median age of 10 years old. All VSDs are of perimembranous type, and the defect range from 2 mm to 7 mm, with a fluoro time between 6 minutes to 40 minutes. Transient ventricular arrhythmias noted upon crossing of wire. No other major complications were noted at that time, which lead to another retroprospective study comparing the outcome of VSD closure in a pre-selected patient using a retrograde or transarterial approach and the antegrade or transvenous approach. We evaluate early and mid-term results of the device closure in 72 patients. There were 37 patients for the antegrade group and 35 patients for the retrograde group. There were no deaths nor any complication noted, and there was a device embolization but was percutaneously retrieved using a snare catheter. The results revealed procedural time between these two groups was found to be significantly, and the significant difference in this outcome between these two groups are more in the antegrade group compared to the retrograde group. Data from the midterm follow-up showed, or in the antegrade group, new onset of valvular insufficiency and residual shunts were more often. Our pre- and post-procedural evaluation is through transthoracic echocardiography, which is the mainstay of our diagnosis and hold crucial for the planning of approach. Short axis view may be used to view the membranous between 7 to 9 o'clock, mid-muscular 9 to 12, and anterior defect between 12 to 1. There are common steps during each percutaneous closure, and most of our procedures are done under sedation. Transthoracic echo is the mainstay of pre, intra, and post-procedural monitoring of VSD closure. Vascular access requires venous and arterial for the antegrade, and 2 arterial and 1 venous for the retrograde. After vascular access, patients given heparin to maintain an ACT of 200 and an IV hydrocortisone for contrast reaction. Routine hemodynamic studies done and left ventriculogram to visualize the defect. MFO or conar MF device is a double-sided screw which can connect both sides of the disc. Hence, the device can be delivered through venous route, through an AV loop, or through an aorta without the loop, which ultimately simplifies the procedure. Here are some of the VSD cases that we've done. This is a case of BK, 16-year-old female diagnosed with VSD. The echo revealed perimembranous, 0.6 centimeter with left to right shunting with a systolic pressure gradient of 140 millimeter mercury. The defect was crossed by an 035 hydrophilic long terumo guide wire. The wire was snared by a 15 millimeter gooseneck catheter at the PA and exteriorized from the femoral vein, establishing the AV loop Then a French 6 delivery sheet was advanced. Once the tip of the delivery sheet is inside the LV cavity, the MFO device 10.8 is loaded in the delivery sheet. The device is advanced to the French 6, making the pigtail as a landmark for the interventricular septum, slowly pulling back with a repeat LV angiogram and transthoracic to check the device correct positioning. Once the MFO is in the right position, it is released from the cable. This is a case of a 15-year-old male diagnosed with an apical muscular VSD by echocardiogram. An LV angiogram revealed multiple exit with aneurysm measuring between 5 to 8 millimeter. We used a multifunctional occluder, size 10.8, using an antegrade. Initially, we did the retrograde approach, but due to its acute angulation from the interventricular septum, we turned to the antegrade approach to an AV loop technique. Once the device is in position, a repeat LV angiogram and checking through echo, the device was released from the cable. This is a case of a 13-year-old male diagnosed with perimembranous VSD. LV angiogram revealed VSD defect of 3 to 4 millimeter. The defect was entered through a retrograde technique using an O32 hydrophilic wire. Transcatheter closure with an MFO A6 was done. The LVDs of the occluder is almost touching the cusp. So we reposition the device by pushing the LVDs down to the apex to adjust the device, and a repeat angiogram revealed a well-seated device and subsequently released from the cable. So 15-year-old female diagnosed again with VSD. Transthoracic echo revealed a perimembranous type with septal aneurysm measuring between 1 to 1.3 centimeter with an effective shunt of 0.4 to 0.5 with a mild turbulence noted at the right ventricular outflow tract. The pulmonary pressure was normal. The LV angiogram revealed or noted to have a defect size of between 1.7 with 2 right ventricular exit. The first exit was closed using an MFO size 1412 through an antegrade technique, and a repeat LV angiogram showed 2 right ventricular exit. Another exit was closed by an 8.6 millimeter MFO and advanced to a retrograde technique. A repeat LV angiogram and an echo was done to check the position and showed a good position of the device after implantation of the 2 multifunctional occluder. The last case is a case of VSD perimembranous, measuring 0.4 with right coronary cusp prolapse or RCC prolapse. There were no significant AI noted. The LV angiogram showed revealed 4 millimeter defect. It was closed by using a retrograde approach. An O32 wire was crossed the defect with French 6 delivery sheet using an MFO initially with 8.6, but unluckily the device embolized, but later retrieved, and a 9.7 MFO was deployed. So now it's in the correct position. It has a good hold. Upon checking on the aortic root, and subsequently released from the cable. So in conclusion, closure of VSD is safe and effective in pre-selected individuals. MFO device is suitable for many types of VSD due to its design, which can fit both perimembranous and muscular. As long as it's in the small to medium size, it can be delivered through a retrograde and an antegrade closing technique due to its double-sided screw, making the device efficient. It's very soft, which minimizes the risk of an AV block. And lastly, it can adjust its weight, length, and angle between the disc and the septum. Thank you very much.
Thank you very much. Now, any questions to the last lectures, to the two lectures? VSD closure with the MFO occluder.
Thank you very much. Do you have any experiment with subaortic VSDs with this? And what's your advice?
Yeah, we had 2 cases of subaortic. As long as it would not touch the cast, you're good to go. I did one that I invert the side, the rim, the RV
device.
rim. I invert it to the left side, and
It's better.
it's better, I think.
Thank you.
Okay, thank you very much. I think we have to go on.